Okay, this is the cast that I have prepared from that one of those impressions that I made for this patient. This is a immediate extraction and implant placement, and I managed to place straight multi-unit abutments for all the 6 implants that I placed in order to have good passivity. You can see the differences in the depth of the platform, multi-unit platform. In some of them you cannot see any of the multi-unit at all, but in the anteriors, if you see, like, you can see a little bit of multi-unit, which means that they are a little bit on a superficial level compared to the other things. So the others, the posterior ones, both on this side and also on this side, they are not really very superficial. They are almost like 3 to 4 millimeters deep. You can see this is what you're talking about. And this is the second impression which I made for this patient, and many of you answered that like I might not use this impression, but actually this is the impression that I'm going to use. This is the impression that is technically correct. If you see this blue portion, like, this is the implant jig that I fabricated, and I mean verification jig that I fabricated from this cast. I have a video for that. I'm going to post that. And for first impression, which looked very nice with the orange color wash, that one was taken without connecting the impression copings, and it actually resulted in a lot of movements of the analogs inside the impression. So I knew that it might have a problem, so I retook the impression with a verification jig. So this is the multi-unit analog. So the analog goes inside the impression coping like this, and then it has to be screwed in from the other side. So you have the holes, you put a screw in from here, and you're going to connect it. After you connect, you're going to move this to check stability. It should not move. Now it's not connected, that's why it's moving. But normally after you connect, like, it should be stable and it should not move. That means it's rigidly fixed, and you're safe to make a cast. I made a cast, and I knew the components were moving because they were not connected. So I used this cast as a primary impression for this patient, and then I made this impression. So the problem with this impression is, like, many of us, I mean, you notice like there is obvious defect on this lingual side, but this is not going to be a big problem because two things. One of them, like, we are going to make something like FP1 processes, which means like we will not have any flange and only the tooth will be replaced. So the contact of the denture is just going to be around these areas, the ridge crest areas that are connecting between all these components. So the ridge crest is fairly recorded, like, but you also have some irregularities here, but this is not a big problem because this is a immediate extraction case, so the tissue is still soft and puffy and healing. So you can actually, like, add some wax here, make these irregular surfaces smoother, and then proceed to make a cast and prepare a denture on top of that cast. And since we are adding something on top of the impression surface, it is going to, like, occupy some space that is supposed to be occupied by the tissue. So which means, like, the processes can compress the tissue when you fabricate something on this, after adding a small bit of wax in these places, here, and here, also here. This one is nicely recorded. This area is also nicely recorded. This area is also nicely recorded. There is a problem here, some irregularities. The light body did not flow properly here, also here. This one is fairly good. There is also some problem here, and there is a huge void here. I'm not going to be worried about this because my processes is not going to come in contact here. So this is the thing about this impression. But this impression, I feel, will be more technically superior because it was connected before completing. So I did not want to repeat the impression because of this defect, because it takes a lot of time to connect the components and remove the components. The patient is already tired. It's an immediate extraction case, so patient is already sore and irritated, I mean, like, uncomfortable. So no need to repeat this impression. We are just going to place some wax here, drop in some wax here, make these surfaces smooth with some molten wax here and here, and we are going to straight away fabricate a cast. Okay, that's it. You can see now the impression is patched up. I've added some wax on the lingual side, to cover the defects, and also I poured in some wax between the places where we had some cracks and small defects. So all of this is filled with wax now. Now I will inject the soft tissue mask around the components, and I will make a stone cast to prepare something like this again. So hopefully this time I will not have any problem. I'm also going to make another verification jig just in case to verify if my second impression was alright. And meanwhile I also have done a jaw relation for this patient by making a trial denture for the upper and also an occlusion rim for the lower. So this is the jaw relation that I made. I made a trial teeth arrangement. So the patient had a chance to see how her teeth might be looking on her face approximately, because she has been with disfigured dentition for a very long time. So something is going to be new, so there should not be any shock for the patient when you deliver a denture. So it's better to do a trial before proceeding to do something fixed or definitive. So this patient also had a lot of overjet, which means like she's in a class 2 skeletal relationship, so that also needs to be balanced. So one of the advantage of having a class 2 relationship in this case is like I did not use angulated multi-units to correct the angulations. The angulations are actually like slightly coming out buccal. The screw axis might be coming near to the incisal edge of the incisors in this place, but because it's class 2 I have some chances to keep the tooth a little bit outside and then keep the screw axis more on the lingual side, or that's what I'm hoping to do. So the jaw relation was done like this. The soft tissue mask has been done, and also the cast has been poured with die stone type 4. Now we are going to retrieve the stone cast from the impression. For doing that, we are going to release all the screws from the back side, from the hole that we made. 1, 2, 3, 4, 5, 6 implants, and we are going to remove all the 6 screws, and then we remove the impression, or release the impression from the stone cast. So it's just enough to release the screws, no need to pull them all out. But just for this video I'm going to remove all of the screws outside. I'm done with 2. Third one. Fourth one. Fifth one, and then the last one. Now we'll try to remove the impression like any normal impression. Sometimes because the components are deep inside, it might be difficult. You also can see that the soft tissue mask got pulled out into the impression. It is normal. Just remove it and then you can fix it onto the stone cast. This happens because the components are really deep inside. Imagine having a stone cast completely without any soft tissue mask. The impression will not even come out. So now we have removed it and replaced it. You might feel like there are a lot of irregular areas between the soft tissue mask and the cast. That doesn't matter, because after you fabricate the processes, finally you will add a little bit of whatever material you're using, ceramic or acrylic, to make the pontic area smoother. The pontic area is not smooth. You can see a lot of wrinkles in between each of the components. We're not going to directly exactly follow the contour which is present here, because this is a contour immediately after the surgery. So you need to make the processes more smoother in the pontic area, and the soft tissues will heal around the smooth pontic areas, and will be ready for a great final restoration after a few months, probably 3 to 6 months.